Okay, so if you've joined us to learn about occupational therapy strategies, maximizing hand function, and feeding, you've arrived at the right place. I'm Paige Nuez, Director of Family Empowerment at the International Rett Syndrome Foundation. Our board of directors and all of us at IRSF want to thank you for being with us today. Your participation, engagement, and is critical to your child's health and well-being and your own health and well-being. Continuous awareness and empowerment are critical to our shared success. So I say this both as a parent to a beautiful teenager with Rett syndrome and as your advocate at IRSF. We want you to be as educated and empowered as possible as you care for your child and as you speak to others about your child, or for the professionals with us today as you do the work in your field of interest. So we welcome and thank all families, caregivers, clinicians, therapists, and even industry for being with us today. Next thing is we want to make sure that all information on our rare disorder is available to anyone who wishes to avail themselves of it at no charge. And we want to thank our donors and supporters for that shared belief. Especially, we'd like to thank Acadia, Novartis, and Taysha for sponsoring our 2021 programs. Their support allows us to connect and empower you with best practices and key information in the here and now as we work to advance research. And speaking of advancing research, I'm sure all of you saw the press release on Monday, December 6th from Acadia that they reported positive top-line results for the Lavender phase 3 study of trofinetide. Now, that does not mean that the compound is approved or prescribable in Rett syndrome. What it means is they've submitted their findings to the FDA, and it will be some time while they go back and forth and review the analysis and have discussion. We encourage you to visit our website and read that press release, and we'll continue to share information from Acadia as learnings come from that analysis. And I want to say a very, very special thank you to everybody who participated in Giving Tuesday in the US last week. We had set a goal to raise $100,000 on Giving Tuesday, and you all doubled it. Our community really turned out. We raised $200,000 in one day of giving, and that's a lot of support for our research programs, and we thank you so much. Okay, now I hope all of you are planning, if you are able, to join us in Nashville, Tennessee, April 27th through 30th for our Ascend Summit. This is the first time that we'll be together in a long time, and we are gearing up to unite our community, bringing together parents, families, clinicians, researchers, and Rett organizations to overcome the challenges of Rett syndrome and reach the summit of hope and healing, which is ultimately a world without Rett syndrome. So please register now, visit our website, learn all the information. Rooms are booking really quickly. So we encourage you to book your room and book your registration, talk to your family over the holidays, and make your plans to see us in Nashville in April. It will be so great to see everyone again. I hope you can join us. All right, so let's get started. We have a lot of information to cover today. We know that our individuals with Rett syndrome often have difficulty controlling hand movements. It's one of the key features of Rett syndrome. And we know that this can lead to frustration in using communication devices, participating in adapted activities, and doing pretty much most daily activities. Mealtime can also be challenging because of decreased motor skills when chewing and swallowing, as well as communication issues in relaying what they want and accessing communication devices. So many of us universally face these issues with our children, and finding a trained therapist who understands Rett syndrome is key to understanding and creating reasonable goals, actionable goals, managing expectations, and perhaps recovering gains lost during the regression period. We're so excited to have Todd Levy and Emily Scott with us today from the Children's Hospital of Philadelphia, which happens to be also an IRSF Rett Center of Excellence. And they're going to join us today to discuss strategies that they've seen work, outline the criteria for you to look for a therapist in your community who will help you on the goals that are important to you and your family, and meet your loved one's needs. So what I'd like to do is stop sharing my screen now and invite Todd to bring up your slides, and I will go on mute, let you all take over. And as you're pulling your slides up, I'll remind everybody to please submit your questions in the question field. We will field those at the end of the presentation. And we do have on hand all of the questions that you pre-submitted at the time of your registration, and Todd and Emily will be answering most of those in their slides. So thanks so much for being with us today, and tell us a little bit more about yourself and what we're going to talk about today.
Great, thank you, Paige. Are you able to hear me?
Yes, you sound great. We see your slides and your audio is wonderful.
I'm Todd Levy. I'm an occupational therapist at the Children's Hospital of Philadelphia. I have about 19 years of experience as an occupational therapist. And prior to being an OT, I had some training in basic science research, in neuroscience and behavioral psychology. I was not fully trained as a PhD researcher, but it does give me a little bit of a unique background, and I think that'll come across today. My primary areas of specialization have been brain injury over the past 20 plus years, traumatic brain injury and pediatric stroke. So I'm relatively new in terms of really seeing children with Rett syndrome on a regular basis. And I'll be quite upfront and honest about that. And I think it kind of, in a sense, helps me to connect with you today as parents when we're all trying to learn more about Rett syndrome. I'm going to start by talking about the role of occupational therapy. Our field is very broad in scope, and many of you probably have already realized that many OTs tend to have different approaches and different strategies. There's a lot of variability within our practice. I'd like to try to explain to you how OTs tend to think about everyday problems and diagnoses, and how we can kind of work together between parent, child, and therapist to solve problems. Then I'm going to take you on a recent journey that I took through the literature to figure out what do we know from the research in terms of how OTs can help families with Rett syndrome. And then next, my colleague Emily Scott will talk about feeding therapy and transition to adulthood before we conclude and take some questions. So the role of occupational therapy, we really focus more on problems than diagnosis. And this is what makes us a little bit unique compared to other therapy fields and certainly medical fields. That gives us, I think, an advantage when it comes to an orphan diagnosis like Rett syndrome, because we don't necessarily think about things in terms of what is this specific diagnosis. We think more about what are the problems that you're facing in daily life. And so in a sense, that's advantageous. We kind of in a nutshell, I think, if you ask 100 of us to define OT and what we do, you'll get 100 different answers, but I think we would all talk about participation in meaningful activities. Meaningful activities could be things that your child wants to do, things they get enjoyment out of. And they also might be things that they just have to do, because we all have to do things that we don't necessarily like to do. And that in childhood really tends to involve parent goals. And then a little bit more specific to Rett syndrome is accessing communication devices. In most cases, it's going to be a speech language pathologist that will drive this intervention in terms of, how is your child going, what are they going to communicate using the device in terms of, are they going to spell words? Are they going to put words together to make phrases? Or are they going to do things communicate a little bit more simply in terms of indicating which picture they want to use to have an automated response. But then OTs can come into play if they're if there's an issue in terms of optimizing how to control the device, whether it's a hand arm movement that needs to get a little bit more controllable to make it easier to access the device, or keeping the head nice and still to use an eye gaze device. And then reducing self-injurious behaviors or other behaviors that might seem to get in the way of function. A basic way that we tend to think about problems as we go through, after defining the problem together with you, the parent, we'll think about what are aspects of the person, the environment, or the person's occupation that we might be able to change to help solve the problem. So as an example, problem that's fairly common in Rett syndrome is, say your child has a skin infection related to constant hand wringing and mouthing or drooling onto already irritated skin. If we're looking at the environment, we need to do a lot of assessment. And that really goes beyond just, okay, well, my child had an hour OT assessment. That's basically nothing. We really have to get to know your child very well over time. And a lot of times we really need you to keep, we'll ask you to keep a journal or fill out a chart to really help us understand what's going on around a given behavior. So we might start to realize, and I think the assessment is maybe even the harder part, something that's linked to the behavior causing the problem. So maybe we notice, or you notice, oh, it tends to be, there's a lot of this hand wringing in noisy environments. And sometimes the solution is becomes fairly obvious. You can avoid noisy environments if possible. We might be able to help you prepare your child for the noise so that there's less anxiety and therefore possibly less of the behavior. Or maybe trying to use headphones or something like that. We might look at the level of the person and think about what can we do there. And this is fairly common where we might use customized or semi-customized splints or gloves to reduce the friction of the hand wringing. And in some cases, it does seem to just disrupt the behavior in some way that we don't really understand how. We'll talk a little bit more about that. We might identify what comes really from the psychology literature or ABA therapy. The term is antecedent behaviors. Antecedent meaning just things that happen before the unwanted behavior. So it might be noticed over time and really looking carefully at things that, oh, the hand wringing is happening more vigorously when I walk away from my child. Okay, then what can we do? Can we maybe set up a video or some activity that keeps the hand or the mind otherwise occupied and reduces that behavior when you walk away? Obviously, you do need to walk away sometimes. And then the last sort of category of area we can look at is occupation. So we're OTs, we're particularly good at helping to find people discover and optimize their participation in all types of hobbies and professions, different types of play for children. And sometimes we'll work under at least the theory that, well, if your child is really occupied and engaged in an activity, perhaps that will reduce the behaviors that are causing the skin problem. And then as always, you really want to we'll talk more about this, you want to try one thing at a time. So if there's no change, it's not working, stop. You're probably wasting your time and doing something that you don't need to do. And then okay, that doesn't work, we need to try something else. And it may be something else within that category, or okay, we've looked at 2 or 3 things about the environment, doesn't seem to be helping, maybe we should go to the occupation category now and try that. Types of services. This is a little bit specific to the United States. I realize and apologize for that, but I won't spend too much time on it. Most of you are aware of the Early Intervention System, or EI system. And this is a service provided by the state. In most states, it's free. In some states like New Jersey, there's a sliding scale. And the therapy happens in the child's more natural environment, in the home and daycare setting. And there are specific advantages to that. It covers birth to 5 years old in the United States. I want to make this distinction between the early intervention system as a way to organize these therapies and what the research or academics just call early intervention. Because the idea of early intervention when it's studied, really just means that we're intervening early. And that seems to be, the more we study it, the more and more important it seems to be, not specifically for Rett syndrome necessarily, but for everything that we study. So we will talk a little bit more about early intervention in terms of just intervening early. Apologize, there's a little bit of a delay on my animations here. The next category, I believe, is going to be school therapy. So OT services provided in the school setting. Typically, not always, but typically, that will be limited to accessing the school curriculum. So the school might say, well, our responsibility begins and ends with accessing the curriculum. So if it's seeing what's going on in the classroom, if it's managing books and papers, if it's things related to self-care, like using the bathroom, you may find some differences there. You might get some pushback depending on the school, the therapist, the district. They might say, well, that really isn't covered by school-based services, so we can't help you. Others might help you. Outpatient occupational therapy, where you go and take your child once, maybe twice a week, rarely 3 times a week or more, to a center, whether it's a rehabilitation center or an outpatient clinic, a place like the Children's Hospital of Philadelphia, where we have OT outpatient services. It's pretty broad in scope, with varying limitations based more on healthcare insurance. We certainly are experts at self-care. So if you are having a problem related to self-care and your school therapist is not helping you with that, that's certainly a good reason to come to outpatient OT. We tend to be a little bit more medical in training and an approach. So things like customized splinting, where the regular off-the-shelf kind of splints, or where you take a couple of measures and then order a splint, those don't seem to be working. We can do a lot of customization typically in outpatient occupational therapy. General rule of thumb that I talk about with all diagnoses is that more therapy is not always better. You can think about it like as if you're trying to learn a new sport or a musical instrument. If you start if you practice too much and just get totally sick of it and it turns you off, or you burn out from it, or you're making progress maybe in your lessons, but it's not necessarily generalizing to playing with a group of people, then those are just a few of the really good reasons to take a break. So I recommend episodic care. Really don't feel like you need to be in outpatient occupational therapy for forever always. I want to change gears a little bit and take you on this sort of research literature journey that I recently took myself on. This was not a complete literature search. It's a fairly sensitive search looking at the terms Rett syndrome and occupational therapy. I found a whopping 6 publications. Now, I probably would find more if I broadened the search a little bit more or used a little bit more sensitive methodologies to search, but this is a pretty big search. I found 6 publications, went through them all quickly. There were, most of them were quite old. Most of them were case studies or relating to a few cases per paper. Most of them described a bunch of different interventions, so you can't really know which one was related to the outcomes and which one were related to one intervention or the other, or just due to chance. And a lot of the papers were pretty poorly described, the interventions, and didn't use objective outcome measures. There's a lot more we can consider. So then I did a search for Rett syndrome and behavior therapy. I found 18 articles. For a little bit of a comparison, and because I think there are probably things we can learn by looking at the autism research. I searched autism and occupational therapy, I got 87 hits. Just for comparison's sake, more than anything else, cerebral palsy and occupational therapy, I got 331 hits. Looking a little bit further, so this was a recent review of non-medical interventions for individuals with Rett syndrome, a systematic review. So it wasn't just simply limited to occupational therapy, but probably includes things that fall within our scope. The author set up certain criteria in terms of what kind of quality do we want to do we want to review, and what kind of quality is not good enough that we won't include in this review. So they found 13 studies of adequate quality that they wanted to review, and they found that they were primarily looking at communication interventions, which is very important. And again, OT has some role, it's not a primary role, but we play some role in that. All studies reported a positive outcome, which is good news. They generally found methodological challenges about being able to generalize the results or standardization of what was being studied, lack of follow-up, so they may only have looked at the outcome like right after the intervention or very shortly after the intervention. And they were all very, very small groups of children. One study that's particularly a particularly important non-medical study I want to spend a few minutes talking about, environmental enrichment interventions for Rett syndrome, an individually randomized stepped wedge trial. The study was led by Jenny Downs, who's a physical therapist, a PhD researcher in Australia. Really has been, many of you may know her, have seen her talk. She has been studying Rett syndrome very specifically for many years, and really develop specific measurement tools for Rett syndrome and interventions for Rett syndrome. So this was a study that I read and then talked to her about to learn more. There were 12 girls in this study, which is a lot for a study of Rett syndrome, still small for a scientific study in general. Average age was 3 years, and the age range was 1.5 to 5 years of age. So young children. The intervention was termed environmental enrichment, and we'll talk a little bit more about what this really is, but it basically is what it sounds like. It's enriching the environment. And many years ago, I actually studied this in animals, and what we do with animals is we enrich their environment by putting them in, housing them in cages with more animals. So they have social experiences. They have toys and different things to look at. We change the decoration of what they can see every few days so that they seem to have like new experiences. We enrich their environment. When we study environmental enrichment in humans, we tend to look at preschools and different environments that are just enriched. They're places where your child gets social experiences, gets exposed to different visual stimuli and sensory experiences and learning experiences. So it's a very general, broad term. The therapy was done in a group setting. Part of the reason why was to get this enriched experience. But there was almost a 1-to-1 ratio of trained physical therapists to children. So one therapist per child, more or less. And it was done 2 to 3 hours per day, 6 weeks for 6 months. That is a massive, what we call dose of therapy. That's not a dose of therapy that you're going to find for your children. I think that's safe to say almost anywhere in the world. And we'll talk about how they did that. Some measures they use specifically developed for Rett syndrome, the Rett syndrome gross motor scale. It looks at 15 different gross motor skills like sitting, standing, walking, and measures it by how much assistance does the child need to complete those tasks. We know that the scale is sensitive to changes in Rett syndrome, so usually we expect it to decline over time. They looked at this compound that we produce in our own brains called brain-derived neurotrophic factor, or BDNF. We don't know a whole lot about this, but it seems to be involved in a lot of really important things like brain development and protection from brain injury. And it's known to be decreased in children with Rett syndrome. And we know that exercise and environmental enrichment in animals increases the animal's own production of this stuff in our brains. Doesn't necessarily mean that helps, but it gives us some idea of like maybe this is something we should be studying. They also looked at some rating scales for mood and sleep. And the results were pretty eye-opening to me as a therapist. They found that the children on average needed less assistance to complete gross motor tasks, and that was a change of on average 8 points out of 45 points on this Rett syndrome gross motor scale. That's a pretty big change. You need at least a 4-point change for it to really be considered an actual real change, and not just based on like just a chance whether you went through the program or not. Your score might go up and down by 4 points, but it went up on average by 8. The other interesting finding is that there was very little to no change over the first month or two of treatment. And then after 2 months, there was a gradual steady improvement for the remainder of that 6-month period. They found an increase, a 2 to 3-fold increase of BDNF in the blood of these children. And we really don't know exactly what that means, but it at least gives us more information. And it just kind of links this to other diagnoses and just typical development. We know that in typical development, BDNF does seem to play a very important role. So it's kind of good just to keep in mind. They found no changes in sleep, which the investigators interpreted as a positive thing, because their theory was, well, this is a really intense treatment. The families moved from all over China they relocated themselves to participate in the study for 6 months. So it was a big change for them. They were living in a different environment. And so it probably was something of a stressor for the children and the parents. So just showing that there was not a problem, a worsening of sleep problems is good in and of itself. I wanted to find out a little bit more about, what did this treatment look like? So I had a Zoom with Jenny Downs, and she said that the therapy sessions looked more so like a typical therapy, PT, physical therapy, or in some countries, physiotherapy sessions look like, as opposed to like a classroom, like a preschool or a kindergarten kind of activity session. Although it was sort of a hybrid between the two. Their focus was on what they call uptime interventions, which is just what it sounds like. It's getting up and getting moving. They're all physical therapists, so they really challenge the children to just move more. And the challenges were guided by a physical therapist specifically for that child. So it wasn't just everybody in the group working on the same set of goals. It was each child having their specific goals, specific challenges. But it did look something like a kindergarten or a pre-K kind of a classroom. It was social. They tried to make it fun. They started and ended every day with a song. They encouraged the children to look at each other. And what they found, at least subjectively, and I saw some video of this, is that the children really seemed to look at each other, engaging in challenges, more so than they look at us therapists or parents or typically developing children. It seemed to be that they were able to get the child's attention more so than in typical kind of environments. And they allowed for increased time for the children to process instructions and to plan through, how am I going to do this motor challenge? So how did they do this? How is it feasible? Because that was my first question. It was, oh my God, like I can't provide this. This is 3 hours a day for 6 months. How'd they do it? And basically they said that this was a very unique set of circumstances. And it was a joint effort between the University of Western Australia. Australia does a lot of great rehabilitation research in general. They got a private foundation grant, and then they worked together with this Rett Syndrome Comprehensive Research Institute in Shenzhen, China. And they found, they were able to find families that was pretty, I think, specific to cultural things there, where they were just, they could pick up and go from all over China and relocate for 6 months. The system just sort of allowed for that. And so they had funding, they had the right environments, and so there were a unique set of circumstances that allowed them to do this. And they know that this is not something feasible for people to do in the clinic. And so one of the next steps is trying to figure out, can we drill down and find out, what are the important ingredients of this treatment that we can then provide to everyone? Do you need this massive dose? Maybe if we know you need it, then we figure out how to make it happen. But let's try to figure out how to make this more feasible. So I do think there's enough that we know about environmental enrichment, and just sort of the obvious, well, everybody wants to enrich their child's environment, and we just know that, that's a good thing for kids. So let's talk a little bit for a few minutes about how we can provide environmental enrichment for your children. So this study is not enough to really rely on please don't go into your savings account and move and try to find someplace that's going to do this, because it doesn't. This one study does not mean that this is going to help your child. But there are probably some things that we can do to to do some of these things. So think about, what does a good school look like? You walk into a good school, there's going to be books everywhere and computers, and there's going to be banners and decorations and trophies, and lots of kids around, but at the same time, it won't be chaos. There'll be order in the hallways. There'll be, people talking to each other. And so I think that's one way to think about an enriched environment. How does a parent enrich a child's own environment at home or elsewhere? You make them feel safe and free to explore. Again, you have the same thing, books around and pictures, maybe you put stars on the ceiling. You try to provide as many different experiences for your child as you can. You try to provide challenges that are not so hard that they're too frustrating, and they're not so easy that they're just not going to teach your children anything. You help them with homework. You give them as much attention as you can. You try to engage them, and hopefully you have a school or a camp, some sort of daycare that really gets your child engaged in some sort of activity. I think that's the key. I like to think about what I call enriching moments. So they're like ways you can do this here and there. Can you start working these things into your daily routine? So one thing probably for most kids with Rett syndrome, because they have such trouble communicating, is they probably don't have a lot of choice over anything that happens to them. So can you start with like giving them a choice over what they're wearing in the morning? Do you want the red shirt or the blue shirt today? Whether you point to it or you work with your speech therapist or your OT to come up with a way to help your child communicate that. What food do you want to eat first or second, or a choice over what their meal is going to be. Singing songs to them when you're in the car, in a waiting room, or in line. Sharing a video of your child, something that you want to see more of. So I think another thing with Rett syndrome is that we or you will see things sometimes, things that your child will do sometimes, but not consistently. Try to capture it on video. Go to your therapy team and say, "Ooh, we want to see this more," and see if we can help you figure out how to get that to happen more. Some creative ideas for environmental enrichment. Science museums can be a great place to just kind of walk around and find what seems to get your child's attention. Certain types of visual stimulus or touch sensations. Instead of having to go buy a bazillion things or find a therapy gym that has a sensory gym, just walk the halls of a Target or a dollar store or a science museum and see what captures your child's attention. Novelty tends to just in general capture people's attention, children and adults. Sometimes for some people that's going to be animals or pets, maybe an aquatic environment, a pool, maybe new music or odd sounds, things that just kind of, what is that? That's new. Rotating toys in and out of your child's room. So like if a toy just the child gets bored of a toy, sometimes you can put them away for a few days and then you bring them back into the rotation and they're like new again. If your child needs consistency, try new things in a well-known environment. So you can try to introduce new things, but still have some consistency. I want to talk a little bit about music therapy, both because that's a good segue. I think music is enriching to many of us, and because there just seems to be, there's an emerging literature of research studies for music therapy and Rett syndrome, and there seems to be more and more coming out about music therapy in general for a bunch of different conditions. Most of them are still case reports, but they do seem to suggest improved motor outcomes, listening, and communication skills. There's some really interesting research in animals even where they're played music, and they're finding that the music is increasing BDNF in these mice. There's now even an animal model of Rett syndrome. There's a couple studies in Taiwan that are new, and one study found increase in social behavior of these animals that have a model of Rett syndrome, and also increased BDNF after music was played for them for long periods of time. And then the same group did a human study. It was very hard for me to understand, to be honest, and I'm not sure if it was a translation issue or if it was something else, but I do have a lot of questions about the findings. Nevertheless, there was 96 hours of music provided to children with Rett syndrome over 6 months, 11 kids, and then a control group of 12 kids. And they found improved language, social interactions, and hand function. They also reported improved parent stress, but I really couldn't couldn't see that in the paper in terms of the actual objective data. But there seems to be something to that. Can we learn from autism research? You know, on one hand, I certainly don't want to say Rett syndrome is the same thing as autism. It certainly is not. But again, occupational therapy is more about problems than it is diagnosis. And there's lots of common problems that children with autism and children with Rett syndrome have. So can we learn something from autism? So I turned to the autism research as part of my journey here. And I thought about, well, in autism, there are things like stereotypies, and they're called restrictive repetitive behaviors. And that's fairly well studied. It's certainly in comparison to stereotypies in Rett syndrome. And there's a few findings. One is that these behaviors in autism are not linked to object exploration. So if you just reduce the movements, these repetitive movements in autism, it doesn't result immediately in just a child being able to, okay, my hands are free. Now I'm gonna touch objects and hold things and interact with things more. It doesn't do that, unfortunately. And these behaviors don't seem to be correlated with specific thinking skills or sensory or motor issues. People have studied or at least thought about, you know, why do children with autism do this? And there are just different theories. Some think it's related to anxiety or stress, some attention deficit. Some people think that it's related to this sense that maybe these kids need to just feel something that's the same all the time. And they haven't really figured it out, at least yet. And so because we don't know why they're doing it, it makes it hard to intervene with a specific treatment idea. Does blocking them cause anxiety or discomfort? Or does it make them feel better? We don't know. So you really have to look at that for your child specifically. So there are some case studies, just, you know, one single child, and I hear about these things sometimes too in our clinic at CHOP, that you put a splint on a child's arm that reduces the stereotypy, they seem calmer and or they can do functional tasks better. The research does not tell us if that works for most kids. If it works for your child, great. But if it doesn't, don't get stuck on that, because we really don't know if it's a research-based treatment or not. We really don't know if it works. If it works for you, great. If it doesn't work for you, don't get stuck on it. In autism, it's been shown that certain behavioral interventions can reduce these stereotypies. But again, it doesn't necessarily result in some improvement in daily living skills. So we haven't learned much by looking at autism here. Here is another place we can learn from autism. This is a big review of effectiveness of interventions to improve social participation, play, leisure, and these restricted and repetitive behaviors in people with autism. A systematic review. It just reviewed things within the scope of occupational therapy, so it doesn't include everything in the world that people have done in this area for autism. Some of their findings was that there was strong to moderate support for group-based social skill training programs, stronger for social skill training programs in the clinic setting or in places like school or camps. And then a little bit less, but still some support for groups done through computer-based interventions. There's some support for social communication, strong support for PECS, picture exchange communication systems, which you may or may not have heard of. You can talk about that with a speech language pathologist or an OT. Joint attention strategies, and we'll talk a little bit more about this. And insufficient evidence to support sensory motor strategies for social communication. For play skills, not a lot of evidence, but some growing body of research that shows support for interventions aimed at improving leisure participation, particularly strategies in the context of school recess and for social stories, which is usually something that an OT can do. Sorry, just some problems advancing my slides here. So just as a reminder, OT is focused on functional problems more so than diagnosis. So I then backed out even broader than autism and said, well, what can we learn from the pediatric OT literature more in general? Good place to look at this, including parents as well as therapists, is a recent review by Ayana Novak, a PhD OT in Australia, who does really nice reviews and using diagram systems that are more parent friendly than we typically see in the literature. And this was just done in 2019. And you'll see these traffic light diagrams. The things in green, these bubbles in green on top are green light. These are interventions that are proven to have effectiveness for most children, but for certain things and certain conditions. And then the yellow, I know it looks orange, but it's yellow, are, well, okay, there's some support, but you really should take extra time and effort to measure, is it working for your child before you really spend lots of time and money or rely on one of these, by putting all your eggs in one basket. There's even, by their analysis, a worth it line. So anything above this dotted line is considered to be worth it. The yellow things below the worth it line are probably not worth it in terms of there may be too much expense or cost or risk involved, and not enough benefit to really counterbalance that. And then the things in red are things that we know are proven to not be effective, again, for certain diagnoses and certain things. So I'll point a few of these things, these specifics out to you. One theme I want to talk about is that what we tend to see, it's just a theme, it's not always true. The green light interventions are things that are more active therapies. By that, I mean the child is thinking and doing as opposed to just sitting there with things being done to them, like being stretched or being moved without having to really think or do themselves. And then things that, well, I'll just point out a little bit more. The tiny letters underneath the treatments are for what diagnostic group do we see that research support. And in a lot of cases, you'll see cerebral palsy, CP, because that's just relatively well studied. But here, developmental coordination disorder, which certainly children with Rett syndrome have coordination dysfunction. So there's some, it's not specific to Rett syndrome, but I think it sort of helps us think about Rett syndrome. And so green light, thinking and doing. Co-op, it's a little bit beyond the scope of what I can talk about now in terms of time, but co-op is a type of occupational therapy approach that does involve thinking and doing. It's an active therapy, and there's research support for autism as well as CP. So I do think it's something that we should be looking at for Rett syndrome. Things that are more passive in nature, like being stretched, or NDT, neurodevelopmental treatment, is proven, at least for cerebral palsy, to not be effective. And it seems to be a theme that just these less thinking and doing therapies don't seem to be panning out as being efficacious for children in general. When we look at things, that was looking at outcomes of improving motor function. When we look at trying to improve outcomes in terms of daily activities, like is it helping are these interventions helping children to be more independent in self-care? We also see pretty big themes, thinking and doing, and also involving parents and involving practice at home in real life environments. And these are for brain injury, for cerebral palsy, for mixed diagnoses, for feeding, which Emily will talk about. Parent education, it's another theme that we'll see here. Parent education is big. Assistive devices. I think assistive devices is sort of just a common sense place for us to turn to with a lot of kids with Rett syndrome, particularly communication devices. And that's being studied more and more. And as it gets studied, we're seeing this kind of move up from like low levels of evidence to higher levels of evidence. And behavioral interventions is now fairly well studied for autism. And I think, again, we can learn from that for Rett syndrome. And then another theme, what we see down towards the not worth it line, or even the proven to not be effective, is sensory integration and other types of sensory interventions studied for autism, not specifically studied for Rett syndrome. There's maybe a study here and there, and we'll talk a little bit more about that. For Sleep and hygiene, we'll talk a little bit more about some emerging evidence for that, and that's being studied in autism. Again, we see down here for cognitive outcomes and sleep, these sensory interventions are been shown not to be effective, like weighted blankets, sensory integration. If you're using a weighted blanket and you think it helps, go for it. But if you use one and your child doesn't like it, no reason to push it because it doesn't seem to be effective for children when we study it. For behavioral outcomes, we see things like ABA therapy for autism. Triple P is a parenting course, basically, to help parents in general with parenting skills. Token economies, which is basically like a reward system. And then again, down here, we see sensory things, sensory approaches and sensory integration for autism, ADHD. I do want to point out there's some controversy here. There are a group of people, online chats, where some therapists are saying like, hey, you really didn't look at these sensory interventions the right way for this literature review, and it wasn't quite fair. Roseanne Schaff is an OT who studies sensory integration relatively well, and she defines it in a very interesting way. Active, individually tailored sensory motor activities conceptualized in play at the just right challenge that target adaptive responses for participation in activities and tasks. I think if the studies really defined it this way, we probably would see more support. But in the way that sensory integration is often done, it's not showing good support. There is a small study here for sensory integration with 5 children with Rett syndrome by Drobniak in 2019, pretty new. They saw a small increase in grasping skills, possibly in relation to sensory integration intervention aimed to elicit specific responses in a classroom setting. And I think that was more, I think it involves some thinking and doing. It wasn't just like this sensory experiences that you might see. Parenting outcomes, this is important. So are we improving the lives of you, the parents? Things like coaching for autism and children at risk of, infants at risk for CP is often a group that's been more and more studied. Problem solving for autism, mindfulness training, parent education, these things are proving to be helpful for parents. Joint attention to improve social skills and communication systems. So lots of things that are helping a lot of kids. I wanted to talk a little bit more about birth to 5, this idea of early intervention or intervening early, because it does seem to be important for a variety of diagnoses. Most of these studies are not diagnosis specific, but they're mostly based on infants that are born premature or toddlers that were born premature, cerebral palsy, and some children with autism. Those are the most common diagnoses studied for this. They found, by looking at the body of evidence, improved sleep and rest and motor development and cognitive development and mental health behavior. And the areas of support that they're finding involve interventions related to environmental enrichment, parent training. So we see the same themes over and over again. Rest and sleep, reading programs, which is often lumped into environmental enrichment. And it can be as simple as like being read to constantly. Repeated exposure to food for food acceptance, family-centered care, another theme, touch-based intervention. That's mostly for infants. And that's kind of an exception to this theme that thinking and doing is really important to be a part of occupational therapy. Massage doesn't necessarily involve thinking and doing. It can, but this is kind of an exception. There seems to be something to infant massage. Here's a systematic review of OT intervention to improve cognitive development in children birth to 5. Any changes we're finding here are certainly not whopping, but there are some modest changes. The big theme, or it's a small theme, there's just really a handful of studies. They found improvements in joint attention. So this is this ability to kind of share your attention to objects or actions with others. So it's basically how we learn everything. We learn by imitating, watching others. And it's a really important basis of classroom learning, learning all sorts of different skills within and outside of OT and PT. And they found some improvements for infant interventions. And there are 2 preschool studies on children with autism where they kind of train their children to point and to have more eye contact and to engage in symbolic play. This was a little bit more specific to children with rare developmental disabilities. They included Rett syndrome in the study, but it was only looking at what did therapists feel were important. It was a survey for therapists. And they found that parent involvement in therapeutic activities, another theme, family-centered care, having parents involved in writing goals and making decisions and incorporating practice into everyday life, modeling interactions for the child or for the parent to then do with the child, and providing support for play. So what the therapists are thinking is in line with what the research is showing us for a lot of different diagnoses for children. Splints really quickly, sleep really quickly, but importantly, behavioral interventions can be helpful. We know that from autism. And I think you should always consider medical factors with the physician first. Are there certain medications causing the issue? Is it seizures? Before you invest a lot of time and effort or money in a behavioral intervention. Families of children with autism, we're finding through questionnaires, tend to use basic sleep hygiene techniques and find them to be not like immensely life altering, but somewhat helpful. And these are like simple common sense things like trying to have a consistent bedtime and controlling light and temperature. They do seem to improve sleep in some studies without solving the problem, but they're somewhat helpful. There are some small studies of bedtime training through more involved behavioral techniques. And they suggest that it results in more regular bedtimes, more night sleep, and less day sleep, which is very promising. Quickly, if I can advance here, splints. Basically, there are lots of different types of splints. Sorry, I'm having trouble with my slides. If you are using splints, something should be improved, and there should be a goal. It should either be improved function, and you should see and notice a change. Is it the splint designed? Is it meant to help your child grasp some object like a spoon? Is it helping your child to function? And if it doesn't, then stop using it. It might be designed to prevent or improve joint contractures. And when that happens, it really should be limited to sleeping, or if it's during the day, it should be just for a few weeks and then transition to nighttime. It could be protective. We need to protect your child's skin from damage that's happening from ringing or mouthing. So it should be improving something. Generally speaking, I recommend starting small. And this is just one type of many splints. The brand is called Benic, and it's a semi-customized. You can fully customize them with measurements, and then the company makes them based on measurements. It's a good place to start because you don't have to go through a full customization process. You don't necessarily need a therapist who knows how to make splints. You can design them in a lot of different ways just to cover the areas you need to and know more. I just wanted to point out this material, you can ask the company to add to the splint. It's called textured tape, and it provides a little bit of extra protection against saliva or other types of moisture that might get on the splint. This idea that restricting movements somehow calms or blocks the behavior. If you're trying to block mouthing, you can do a larger splint that just simply blocks the hand from getting to the mouth. The studies of that they're inconclusive. We don't know for sure if that actually works to stop mouthing. Again, if you've tried other things, or if you've already tried this and it works and it's working, I don't think you should stop. But I would suggest that you don't start by restricting movements, and you do that if you have to. And then if you restrict the movements, you decide, okay, it's working, keep going. It's not working, stop. If you need to restrict movements, you'll probably need an elbow brace. And elbow braces there's all different types, starting from things that you've probably seen because they're easy to get. Therapists that don't know how to make custom splints can order this together with you. These bamboo braces, they're sometimes a place to start, but sometimes not enough, or not doesn't fit your specific child well. There are some more involved semi-customized splints where there's like an elbow hinge. And then there are like super customized splints. The picture's not popping up here yet. But some OTs know how to make these splints. So they're super customized. We can make them at CHOP and other large OT outpatient clinics. And we can get very, very creative with them. But you may have to go to a large outpatient OT clinic to get those types of customized, very sort of creative splints if the semi-customized splints fail you. I'm going to turn things over now to Emily.
Great. Hi, everyone. So excited to be here with you today. I'm Emily Scott, and I'm an OT going on 14 years, and I specialized last 6 or 7 years predominantly in feeding support and therapy. It's something I'm extremely passionate about because as an OT, what is more important and meaningful in everyday activities than eating, right? And it's not just eating, but it's also growth, nutrition, health, quality of life, social engagement, bonding, and it's complex. So it's some of the most challenging work to help our children with feeding difficulties, but also some of the most meaningful. So I just want to share with you today kind of a big picture thought about feeding and optimizing feeding function, and then dive into a little bit of the specifics about how we might be able to best help our children with Rett syndrome based on what we know and the specific challenges they have. So really starting off here, kind of first talking about big picture feeding function. And it's really important to think big picture because I think we often can get pulled into the meal, the hand to mouth, the bringing the utensil in, what foods are they accepting. But you know, what we really have to think about is all of the factors that impact feeding success. And right here, you know, put this little diagram together, kind of, this is how we think as OTs. OTs kind of think about all different aspects that impact the successful participation in activity. So here, kind of breaking it down into what impacts success with feeding. The personal, biological, physical factors, those are the top 2 boxes. The environment, so seating, equipment, comfort, the sensory environment, and then of course the task itself. So what kind of food and drink? What is the texture, the flavor, the thickness, the routine of the meal length? And at this yellow star here at the center is meant to reflect a success. And what does successful feeding mean? Most importantly, it means growth, nutrition, neural development for our children, and that's really the big picture. So it's always important to come back to thinking big context when you're struggling with feeding challenges and kind of think of all of these pieces because they all impact. So, where you intervene for your child over their life course might vary. If they have a regression with swallowing, you might be more focused on modifying the texture and working with a speech therapist, where at other times you're focusing more on the self-feeding. It can vary, but most important is to come back to this big picture. And here in the italics, I have italicized the things that we know from the literature and understanding of children with Rett's are the most frequent challenging factors for them impacting feeding. So posture and strength, their ability to maintain an upright position to then facilitate safe swallowing and optimal feeding. We know that dysphagia, difficulties with chewing and swallowing, do come with time, which also can lead to an increased risk for aspiration. From the biological factor, things that impact their feeding include aspiration risk, any breathing difficulties they might have, for example, with patients with scoliosis, that might impact their breathing, definitely impacts feeding. Constipation, challenge for our patients. Arophagia, where you might be swallowing more air while you're eating. All these things can impact a child's comfort and their physical sensations while they're eating. In terms of the environment, we know that seating and positioning is really critical for our children with feeding challenges. The equipment that we use can really make a huge difference, and I'll dive into that a little bit in the next couple of slides. From the literature, I have a couple of, cited from some of the works we have here is a group from Australia, Adi and Leonard, where they, did comprehensive questionnaires of 200 children with Rett syndrome and asked families all about their experiences with feeding and growing. And also then in 2014, the same group did an expert panel on people that work with children with feeding difficulties. And this is where kind of these themes of what the biggest challenges are. And, you know, finding that meal length, meals taking a long time is something that parents report as a big challenge. So these are all the kind of big picture factors, many of them that impact feeding for us to consider. Next slide. So how do we help? Right? How do we help with these? So number one, you know, to know about a feeding therapist. You know, as an occupational therapist, I am considered a feeding therapist. But what is feeding therapy? It can look really different in terms of who does it, what's offered in your area. And this is more USA specific in my description here of what feeding therapy looks like in the US. I think there probably is some generalizations. I know probably very similar in Canada, other Western European countries, but it may vary a little bit. Big picture here on the right is to know that a feeding therapist can be an OT, it can be a speech therapist. What really matters is the level of expert and advanced training and expertise that that speech therapist or OT has had. In speech and OT school, there's a basic level that's covered, but the feeding therapist is someone that has gone on to pursue extra training in this because it is such a complex, dynamic, you know, area that you really need that extra training in. In terms of differences, there might be some overlap, but OTs tend to focus more on the physical skills related to feeding. So posture, getting an upright position, ability to pick up, grasp, reach, and bring food to your mouth, using splints to help facilitate that hand use, as Todd touched on, and also sensory strategies, being both in regards to the sensory properties of the food, texture, temperature, shape, and the routines and patterns around feeding. Speech therapists, often the ones more go-to in terms of helping you with the dysphagia challenges with safety of swallowing, if you're coughing, chewing challenges, and they will be the ones that do things like swallow studies to help identify what is the safest feeding plan for your child to do their best oral feeding. And of course, communication during meals. You know, we often think about speech and language therapists, but mealtime and optimizing function, we need to remember how can we maximize communication during the mealtime, because that's going to really help with feeding function. So that is frequently how it's divided, but it could be different. And if you're having trouble with your child with feeding, you know, definitely look to what OTs, what speech therapists are in your area. Where can you find it? So major medical centers, major places often have interdisciplinary feeding clinics. And this is something we have at CHOP that I work in, have it in many major medical centers. And what's really critical about this is that you have so many professionals that are key to your child's successful feeding plan together in one place. A doctor, a nutritionist, speech therapist, OT, to come and sit together and say, what are you seeing from the medical side? What are you seeing from the swallowing, the physical side? Let's make one cohesive plan to help guide this family. And that's really critical because when your care is more piecemeal, it can be more challenging to get them to come together. And feeding is complex, right? Sometimes you might have more challenges in one area than another. And this interdisciplinary team, if possible, is really a great, most recommended thing to do. It's often in a consultative basis. We kind of continue to follow and check in and be reassessed as needed. You can also find feeding therapists in outpatient clinics. In the US, this is often then using your insurance, your private insurance benefit. And as Todd talked about, this might be more like an episodic type of care where you go if you are really wanting to focus on a specific feeding skill, like say, I really want to work on spoon feeding or being able to pick up certain food, or maybe you're working with a speech therapist on trying some novel textures. And this might be when you feel like you might having a regression to come in to work on these skills, or you have these specific goals that change with time. In the school setting, you will find feeding therapy. It is less frequent and it is highly dependent on the school. In the US, if your child is in a specialized education school, OTs, speech therapists will frequently work on feeding. If your child is in more of like a public or private sector, school therapists may be less apt to work on this. And it's all about the government regulations about how much does this goal apply to their learning needs. So the bottom line about this is to ask, and advocate. Advocate to your therapy team at school for what your concerns are related to feeding, and how can your team how can your team address this during the school day? And as Todd talked about early intervention, again, this is like that in the US, that's our early therapy supports. It can vary widely. Again, this feeding support is really dependent on the expert training of the speech or OT. So you might have to really ask, do you have a speech? Do you have an OT that is focused on feeding, and really advocate to get that therapist on your team if feeding is a major concern, which it is for so many of our children. The last thing that I put here in quotation, and not quotations, but the question mark, is an intensive. So there are feeding therapy programs that focus on more intensive times where your child will go for maybe every day, 2 times a day, to work on a specific feeding skill. And the evidence is out there that this can be helpful. It's mixed. But what we know about how children with Rett's learn in terms of doing best with task-specific activities and longer duration repetition of those activities, that is something to consider, and ask your team of therapists if they think that would be beneficial for your child. Next slide. So what do we know specifically about Rett syndrome? What kind of feeding support interventions are helpful? So this is based off of the study out of Western Australia in 2013, where they asked an expert panel about these interventions and what do you think about how effective these interventions are for your patients? So we see there's a little rating scale of number of strength of the evidence, and the lower the number, the stronger. So what the panel of experts agreed upon is that physical positioning and postural support, really supporting a patient's ability to have a good, solid support system. And I'll go into that next slides. And exploring special equipment like utensils, plates, cups, adaptive equipment. That's what we as OTs really thrive upon. That is one of our areas of expertise, is adapting things to your child's individual motor and sensory cognitive needs. Those are what the panel of experts felt were like the most helpful. Lower level, but also agreement of support that the types of prompting, the type of assistance and cues that you give a child as they're learning how to self-feed or they're working on eating is really important. They did feel that the intensive therapies can be helpful, and that direct caregiver training, like Todd talked about before, that really focusing on educating and working with the parent to work with your child versus just I'm the therapist, I'm just going to work with your child, that's not as effective. Because why? Because you're the one at home working with your child, feeding your child, and that is where your child's going to do your best, and that's how we're going to get our carryover, because that's most important. The next slide. So we know we have a lot of questions in the that were given to us about and so important to so many families is, how can I help my child feed themselves, right? Seeing your child lose that ability to feed themselves is really, really challenging. And we know that with the regressions in skills, this can happen, slowly, or there can be larger changes. But there are, and other questions that came into us is it possible? Can we regain these skills? And what's really exciting is there's these two research studies that were done that show that with specific types of intervention, that there's that children with Rett syndrome it is possible to teach them improved self-feeding. So one of these was from 1993 out of Kennedy Krieger, the top one, and basically they took 5 girls in a range of ages 3 to 23 years old. And all of them in the beginning had minimal self-feeding abilities, needed a lot of help. And over a period of 12 to 15 weeks, they did a series of repetitive, trained, graded prompts. So first they would help with physically helping, scoop, bring the spoon to mouth, put the spoon in your mouth, and fading the amount of assist they had over time. What was really exciting is that at the end of the intervention, all of the girls had made significant gains and were participating in all aspects, all 3 portions of spoon feeding. And not only that, at 1.5 to 2 years follow-up, they had all maintained these gains and were participating in all aspects with some varying levels of minimal assist or coaching. This was a similar approach was demonstrated just recently in this study out of Scandinavia with Queffert, where he also looked at 3 girls using this approach and had the same conclusion, which is really exciting and answers that question. It's possible, but you know, we just need the right supports and the right interventions. Next slide. So specifically, how can an OT help? So coming back to that positioning, I remember being in OT school and my professor saying proximal stability, so having your body really, you know, supported, leads to distal mobility, your ability to use your hands well. And that is not just about the hands, but also about the mouth, right? We know that when our body is well supported, then we can coordinate our oral motor movements and swallowing much better, leading to better safety and also better, more positive feeding experience for our children, reducing aspiration and all those things. Also for hand use, that when your body is best supported, you're going to have best coordination and control and motor planning to be able to reach in space, grasp something and bring it to your mouth in a coordinated way. And lastly, comfort equals function, right? So, you know, our children have a hard time communicating to us, but when we can get them in a position that they're most comfortable, then they're going to be most ready and open and engaged to actively participate in feeding. So there are some examples here of different types of supportive chairs. It's going to be very variable across the lifespan, child to child, but the bottom line is that your therapist works with you to find a seat and tray that helps them have an upright position, that their body, their hips, their trunk, their feet are fully supported. So all they really have to focus on is the hand movements and the chewing and swallowing. In terms of equipment and devices, this can really run the gamut. It's highly individualized to your child, but there's a wide variety of things out there. So Todd touched on splinting and braces. Some people find that using braces during feeding to help block repetitive movements or to put the hand and arm in a more functional position for hand to mouth can be helpful. A huge gamut array of specialized utensils and cups right here. In the center, we have these swivel spoons, which helps children that kind of lose it off of, you know, or have a little shaky or tremor. That was one question we got ahead. How can we help spoon feeding with a tremor? There's special devices that are either a little heavier or swing so that when you bring it to your mouth, it doesn't fall off. These angled spoons can be really great for children that have difficulty with the exact coordination of hand to mouth. And here we have an example of a splint with grasping. So if your child has difficulty maintaining that grasp, this will keep the utensil in their hand, even if they let go. So you're not dealing with the flying spoon fork. So a huge array. Bottom line is that you have a therapist that's sitting there analyzing your child's motor challenges and trialing this variety of things to find what is the best fit for them. And then in terms of how do you increase the engagement with self-feeding, their want to participate, their active engagement. Really important to think about how we set up the food. What is the shape of the food? Is it slippery? Is it dry and easier to pick up? What is your child's best grasping ability, and how can we modify the food to fit that for finger feeding? This is a picture here or down there about things that are cut into strips for children that have more of just the gross grasp. So it's much easier to bring to the mouth and eat. Also using different plates and things like this to separate the food so it's easier to target and grasp and not have it fall off. The possibilities are really like endless, but the big picture is that there's so many adaptive strategies, and it's about working with someone who's aware and savvy with them to try them with your child. Next slide. From a sensory perspective, we know our children with Rett's can have sensory differences, hypersensitivities, difficulty with regulation, calming. So while we know the evidence out there about using sensory integration to help with participation is mixed, we do know that using sensory strategies can help your child reach their most calm, focused state to help them best engage in feeding. This is a silly little picture of a baby on a kitchen counter beating a drum. That's probably not how you're going to use sensory strategies, but what you want to do is think about your child and are they in a calm, focused state? Because they're not going to do their safest, best strategy, their safest, best feeding and participation if they're not. So you can use sensory strategies to either alert your child, help to wake them up, be more focused, or to calm. And so you want to think about what are the sensory activities, what are the experiences they have that effect on your child, and you use them prior to or during a meal to get them in that just right state. That's something an OT can help with. And food properties, you know, some children have sensitivities to texture, shapes, flavor, smell. So working with your OT and finding the just right fit of food properties that your child's going to be most comfortable and accepting of those foods. And then in terms of the meal pattern routine, you know, we know that maximizing communication. Feeding is a dynamic back and forth activity. We call it a co-occupation in OT. And what you want to do is make sure that you're really trying to maximize your child's communication abilities with you. Feeding is a really intimate, intense experience. And what's most important is that we're able to read their cues and respond to them. So trying to work with your therapist to integrate any communication systems you have, maybe using a visual system. We've read a lot that a lot of therapists feel that using a visual routine, saying, you know, it's lunchtime, pictures, you know, this is our food, this is our seat, kind of setting up that regular routine around feeding can help prepare, let them know what's coming, and then they're best engaged to do their best work with feeding. Just a couple notes in terms of how OTs can work with the bigger medical team. You know, we do know that some children with Rett's need supplemental tubes because of challenges with nutrition and growth, or potentially aspiration. But what's really important to know is that tube feedings does not mean no oral feedings. That, you know, a feeding therapist can work with your child with a tube to still maximize oral feeding. There's so many things you can do in terms of how long the feedings go over, the volume, when they happen, to work with you to time it just right and give feedback to your medical team about how the tube regime may be impacting their feeding to help, for example, maximize their hunger at times when you want them to participate. There's a lot of options there. And lastly, we know children with Rett's can have an array of GI challenges. So your feeding therapist can be, you know, aware of what those challenges are and help you find patterns, meal times, foods that can help minimize. For example, here, this child is drinking a smoothie, which is a texture that's easier to drink, potentially if your child has some dysphagia or swallowing challenges, but putting in it things that are really high in fiber to minimize constipation, or focusing on foods that minimize any reflux, which are all things that would not contribute to improved feeding for your child. And we've already talked a little bit about caregiver training. That is what's really important here is the train the trainer. Your therapist works with your child, but then when they find something that works well, they work with you to work with your child, because that's going to have the best effect. Next slide. So feeding takeaways. Feeding is complex and multifactorial. We kind of always have to look at that big picture of all the systems impacting it. It impacts growth, nutrition, health. If you can get an interdisciplinary feeding clinic team all together, go for it. If you can't, try and get members of all of those different professions on your team that are able and willing to collaborate. Gains in self-feeding are possible. We've seen in some of these great studies, but what we find is that they happen with like task specific, like having a specific goal, like I want to work on spoon feeding, right? Or maybe it's cup feeding you're working on. And then individually tailoring that feeding intervention to your own child's motor sensory needs. The most important interventions, if we have to talk about what is to focus on, seating support, having really good postural support, and modifying that diet, modifying your child's diet to promote safety, comfort with you know, their GI system, swallow safety, and modifying to sensory needs. The more your child is comfortable, they're going to be more engaged. We see a lot of children who suddenly they stopped accepting food and what's going on, and we learn that maybe they had just started aspirating, or maybe it's a sensory issue. So modifying that diet to help them be most motivated and comfortable. Next slide. And lastly, we just thought, you know, it would be great to leave you with some thoughts about transitioning to adult therapies. You know, there's a great study done by 8 different Rett's Excellence Centers, and our own page was included in the study, which is exciting. And finding at that transition time, the young adult time, what are the biggest needs that healthcare providers feel you need to focus on? And we see that it's important that you have seating and equipment that meets your child's needs. So perhaps like, going to a seating clinic before your child ages out of the healthcare system that you're in. We know that feeding safety continues to be a challenge, so continuing to be hooked in with feeding specialists to optimize that. Having therapists evaluate your child's functional living abilities to help planning for any different environments they may be in. And then last, that we see that the importance of physical mobility and strength and social interaction becomes even more important. So working with your therapist on those types of goals. And therapy in the adult world can look a little different, but if your child is up to age 21, I know US or perhaps Canada, school services are still offered. You can find outpatient clinics through physical medicine and rehab. I know some fewer adult Rett specific or home-based services.
In the interest of time, I'm going to just leave this slide up with conclusions and start going through some questions. We received many questions prior to the talk, which is great. We appreciate that. So I'm just going to go through some of those. First one, what do you do when a child is resistant, uncooperative, or finds therapy aversive? I'm glad this was asked because it can really make everybody feel stuck and frustrated, and can make things feel counterproductive for good reason, because I think when that happens, it is counterproductive, generally speaking. As an adult, what I try to do is think about how difficult it is to practice a new skill in an area that's not motivating, right? Even as an adult, when I know maybe I really need to get better at X, I don't really want to, but I have to. It's easier for an adult to kind of push through that and self-motivate, or realize, think ahead, or there's going to be a reward for this, right? If I do practice getting better at, I don't know, say typing, eventually I'm going to be really happy about that. It's hard for children in general. Children discount the future. So if child isn't motivated, if they're really being resistive to something, I really, generally speaking, start to change something quickly, whether it's my style of interaction with the child, the type of therapy approach. Sometimes we'll even at a place that's a department that's big, like we have at CHOP, we have a lot of OTs. Sometimes we'll say, you know what, maybe I'm not the best fit for this child. Maybe they need someone who is just a little bit different stylistically. I think, from the get-go, if you're a therapist working with a child with Rett syndrome in particular, take some extra time to really try and understand what motivates the child. That can be a goal in and of itself with Rett syndrome. What does each child enjoy doing, and then trying to work that into either your goals or into your treatments. And I think that's where some of the work on the parent's side comes in too, is to help the parent explore different things that may or may not be engaging and motivating, and just go through a trial and error process. And finally, I would say if you need to engage in practice with something that they're resistive to, because it's very important, say it's feeding, and you're just your OT just tried a million things and you can't figure it out. You might need to go to a psychologist, a behavioral specialist, an ABA therapist. You may need to go to a specifically trained behavior professional to help you out with that. Next question was about occupational therapy for spasticity. So spasticity is basically the brain is giving too much signals to the muscles to contract when they shouldn't be contracted. It's really a very big area. It could be easily another hour-long discussion to talk about. I think the good news here is that most OTs, whether they've seen Rett syndrome or not, really have a lot of expertise in spasticity. So you don't need someone who's necessarily has experience in Rett syndrome for this. It's a very big part of cerebral palsy. So if you find OTs and PTs that are experienced with CP, they should be able to help you. Generally speaking, general rule of thumb with OT comes into play here if there's a functional goal. If your child is having trouble reaching out to activate a touchscreen for a communication device, and the OT thinks, oh, it's because of the biceps, the elbow flexors are too spastic, then you have a functional goal and an OT comes into play. And it might be teamwork with a physiatrist, a physical medicine rehabilitation doctor, to use an oral medication or Botox injections to relax muscles. It might be serial casting, it might be splinting, but there needs to be a functional goal and some practice involved in improving the movement, not just, if there's a functional goal, it can't just be a medication by itself or serial casting by itself. There's got to be some functional thinking, doing kind of therapy going on for that. Next question is transitioning to from finger foods to spoon and fork. What is the best way to support that when there's a mild tremor? So Emily talked a little bit about this and showed some pretty low-tech devices that you can get on Amazon, where the spoon kind of swivels a little bit. So when there's tremor going on, the spoon won't spill. There's a couple higher tech versions of that now that's really meant for tremor that's like kind of like you see with Parkinson's, where it's like a back and forth shaking, where electronically the spoon cancels out that extraneous movement and the food doesn't spill. So there's sort of this adaptive approach. You don't necessarily have to improve, use a therapy that's trying to improve the tremor. You're adapting to it, and OTs do that quite well. With Rett syndrome, it may or may not be an actual like shaking tremor. There may be some movement abnormality that's more related to coordination or dyspraxia. This idea that kids can do all the movements involved in the task, but when they're trying to do the actual task of bringing that spoon to mouth, for example, something just falls apart. And so that the approach there is usually a little bit different. It's usually more like again, trial and error, but it's more like looking at different, where is the skill breaking down, different ways to practice that skill, different ways to cue it or keep it going. Sometimes it's an initiation issue or a freezing issue where the kids get stuck. Music therapy may be a way to deal with that. So that needs to be really like kind of thoroughly assessed by an OT. And that's where some more experience with Rett syndrome would probably be better. You know, if the OT, an issue that's a little bit more complicated and it might be easier for a therapist who has experience with Rett syndrome to tackle than someone who doesn't. Next question. So I'm going to skip through some that I think that we really tackled in the slides. Is there basal ganglia therapy to help regain lost skills? So OT interventions really, again, target the functional problems. Although there's some evidence to suggest that OT, particularly OT that involves repetitive practice, can change the brain. We don't really know enough about this relationship to really drive the intervention. I do want to say that the basal ganglia it's a deep brain structure. It's involved in numerous things, has connections with many different other areas of the brain. It's involved in a lot of coordination issues. And so you may hear that your child has involvement of their basal ganglia. So I think it's good for us to know that this is an area of the brain that you're hearing about from neuroneurologists, and that we know it does play a role in coordination. But try and help us understand as OTs where this is causing daily living frustrations, difficulties, and that'll help you tackle the problem a little bit better. Do we have to look for someone specialized in sensory integration or not? So, great question. As you saw from some of my slides, as this is being studied more and more, especially in autism, we know that the studies are telling us it's just not helping very much. And really for autism, Again, it's somewhat controversial, but the evidence is telling us that it's not helping. That doesn't mean that certain aspects of sensory integration therapy can't be incorporated into your care, into your child's care. But it suggests to me that you shouldn't go to the ends of the earth, disrupting your life, trying to find a new therapist just to get sensory integration. And I think when your therapist is saying, I'm doing sensory integration, ask them questions and make sure that they're doing, that they're trying to promote thinking and doing skills in some way, shape, or form. There are ways to use sensory approaches that are also using things that are known to be more effective. Like Emily said, if you know that your child just becomes more attentive and responsive if you say bounce them on your knee, or if your therapist finds a certain sensory experience that helps them get alert and ready to do some work, then go for it. But if you've tried a bunch of these things and none of them are helping, or they help for 30 seconds and don't last, there's no reason to go to the ends of the earth to think, because there's not good reason to believe that they're going to work for most kids. I'm gonna let Paige sort of guide us in terms of time here and other questions that I might be able to answer now.
Yeah, thanks everyone. Oh, great information. Thank you so much for sharing so much of the literature, research. We know that we are limited in the work that's been done in the field in Rett syndrome, specifically around occupational therapy. So I really appreciate the insights and expertise, Todd and Emily, that you've brought to us today. And I hope that it will just inspire the field to engage more in Rett syndrome, specifically because fine motor skills and feeding, chewing, swallowing, positioning, accessing communication devices are so critical to quality of life, engagement, activity, and we are at a bit of a loss here in this field specifically, and you've shared a lot of information. We are at the time limit for our Rett Ed today, but we do have a few questions that were asked in the QA field, and I'm wondering if I can read those, if you can give some brief answers, because I think they're good ones. Okay, so we had a parent who said who would like some ideas about better activities to do at home. Her daughter's become really bored with everything that they've tried. Her hands are getting worse, are really involved. There's only so many walks they can take, and most indoor activities require hand use, which is not of interest to her, and she may even be averse. But I think she's really just bored with stuff. So what do you do? You did a really good job talking about what to do if your child's averse to therapy, but what if they're just tuned out and bored with life? Maybe have aged out of school, don't have a good day program, parents are at home. What are your thoughts?
Yeah, I think engagement comes in many ways, shapes, and forms. And although we generally think about our hands when we're talking about engagement in anything, activities, whether the things we like to do or have to do, it's not the be all end all. So there are many people with many different diagnoses that can't use their hands at all, that still find ways to engage in a variety of activities. So try not to get too stuck on hands always. I would say as a general kind of strategy to think about it that way, and to think about, as a parent, I know my child seems to enjoy X, Y, and Z and doesn't like A, B, C, and D. Talk to your OT, all of your therapy team. Say, here's a list of things my child likes to do. Here's a list of things they don't like to do. How do we get creative in engaging her in the things she likes to do? And maybe if you can move away from the things you don't like to do, sometimes you have to do that. Emily, do you have any other thoughts there?
Sure. Just two other things thinking about when we start talking about not being engaged, and saying when you go outside, clearly that's a big change. So think about what about the outside is alerting, engaging, fulfilling to your child. And And that's a nice time when we think about the sensory perspective, like what sensory strategies help to bring your child into that alert, aware, active state. And that's where we're working with an OT about, experimenting with other sensory-based activities in your home to help them get to that most engaged, alert state for participation, kind of more preparatory, might be helpful, and explore things in your own home environment to do that. I was going to say also like adaptive switches and devices to help your child engage in other ways other than just with the hands or just using what they have. There's a lot of great ways that you can adapt things with different types of switches and ways you can control them. So maybe working with like an assistive technology therapist to explore that.
Also, if your child is engaged in screens, videos, cartoons, whatever it is, you can use that to explore other things. So maybe videotape your child doing certain things when they do them, play it back for them. Maybe it's sometimes siblings or other children with Rett syndrome, if you have other families that you know of children with Rett syndrome, share videos and see if they'll attend to each other via video. And then if pets are totally new to your child, if they haven't been around pets, you may want to see, is there a therapy dog organization or a therapy animal association in your area where they can bring an animal to your house and just see, whoa, does that just totally light your child up, or just because it's so novel, even does it get them engaged?
There's some great ideas. I've also, just sharing anecdotally, I've heard from families that have engaged an art therapist to do some work. And as you said, integrating communication devices, areas of interest, paying attention when we have our kids out, what are the things that they look at and attend to? And then perhaps work with an art therapist who can then help them start to paint those images. So using adapted paintbrushes and things to start a picture, and then somebody can help complete the picture. So it's not the whole motor load is on them, but you're doing an area of interest, you're engaging, you're extending cognitive engagement on those topics. You're walking and you see that there's a particular tree that always catches her interest, or a certain time of day or light. And then she or he can choose the colors, right? And start, those are just ideas that I've heard other people talk about, ways to enrich the environment and maximize on their areas of interest and extend them into other activities. I'd also like to mention there are two research activities that are underway, one in the US and one in Italy, exploring the idea of virtual reality and if the use of virtual reality VR devices can encourage fine motor or even gross motor movement. Those are early stage studies. You can find them on the Rett Research Ready tool on our website, or you can email me if you're interested. And I think that those researchers can help you do those, participate in that research from home. So just some plugs there. Moving on, there was a question if it would be possible for you all to provide a list of all of the references that you did cite so families could access the articles and read them more in depth. Excellent.
Yes, sorry, I forgot to, there's two pages of them here. I'll leave these up for a couple of seconds each so that it gets recorded there.
Great, thank you. Yeah, it'll be captured in the recording. You can access the recording, pause, and take a look at that. And then, so Todd, if you can go to the next one. Another question is a parent's 20-year-old daughter has always been low muscle tone, but just recently her right hand has started to become more closed and tight, and it's becoming harder to open. So would a sudden change like this make you think that maybe some kind of assessment should be done? We know that there can be low pain tolerance or expression of pain in those with Rett syndrome. So, I hate to go there, but it's possible, right, that a fracture or a sprain or something could have happened and not be identified. So if you see a sudden change, what would you recommend? And if a physical issue is not identified, are there hand therapy exercises that you would recommend? I know you've touched on that a little bit, but sudden change gives me pause to think something might be going on.
Yeah, I would, if you have relatively easy access to a physiatrist, doctor of physical medicine and rehabilitation, and they're pretty easy to find. I think that would be a good place to start. And a physiatrist does not necessarily have to have a ton of experience with Rett syndrome to be the kind of starting assessment. Is there some kind of injury that's causing the posturing? Sometimes there is spasticity that's superimposed on low muscle tone. We do see that. And spasticity generally can change over time. It tends to sometimes worsen during growth spurts. It can cause a tightening, a shortening of soft tissues just over the years of constantly the muscle being overactivated. So sometimes that tightening is not surprising. But I think a physiatrist would be a good starting point. And the answer may be maybe as sort of simple as a night splint, or maybe a little bit more complicated, maybe possibly an oral medication or Botox injection, maybe serial casting. That's a few weeks of treatment followed by nighttime splinting. There are a number of options. If they get very, very, very fibrotic from being tight over years, sometimes you need an orthopedic surgeon, but you're probably far from that if this is a new change. I would start with a doctor of physical medicine and rehabilitation and go from there. A neurologist too. If you don't have a physiatrist and you have a neurologist, that's easy to get to. They should be able to assess it as well.
Great, thank you. And I think really in the interest of time, and I know you have very busy clinic days, I think we need to draw to an end. If anyone would like to email me directly with questions, my email is pnues@rettsyndrome.org, pnues@rettsyndrome.org, and I can take questions to Todd and Emily and we can get you some answers. But I want to share, I don't know if everyone can see in the chat, a really lovely parent whose daughter is 51 years old, has given some advice that she received from their family doctor. And it was transformative for her. She said that no one should use Rett syndrome as a stop sign for anything in Rett, particularly hand use and hand intervention. So don't let the literature that says loss of hand function is a classic Rett. So, just stop. I'll write my email in the chat. And I think that is a really good message, that don't let her diagnosis or his diagnosis be the stop sign for making progress in any area of their life, whether it's OT, PT, cognitive, communication. I think that if we believe in our children, very special things can happen. And the most important thing that you can do is get people on their team who have that same aspirational, open-minded thinking. And then they can learn about Rett syndrome. But I think what we really appreciate, Todd and Emily, is that you really believe the sky is the limit for our kids, and that we should never stop trying. And for those of you who are here today whose children are younger, I would say if you're just starting to see hand stereotypies, I wanted to mention that they can change over time, right? So some of them can be very, very pervasive and very frustrating, especially with the hand mouthing. You can have skin breakdown, perhaps hair twirling. You might, be having hair loss. I don't want you to think that those kind of behaviors might persist over her entire lifetime. They can change over time. And you always want the goals that you're working on with your therapist to go with what's going on with her right now. So I don't know if Todd or Emily, if you have any comment on that, on change over time. Sometimes it's related to therapy. Sometimes it's just related to that development, kind of calming down, the regression period, calming down, and you just want to get into those moments of opportunity. And I know the days can feel very long, but change happens.
Right,
yeah.
Change might have nothing to do with the diagnosis. All of our goals and interests tend to change over time. One thing I think I neglected to mention, I talked a lot about parent involvement. Know your child's goals. There are so many parents that I see come to our clinic, and I say, "Oh, what are your child's OT goals in school? What are their OT goals in Alpine?" I don't know. You should, and it's not your fault. But if someone's not telling you constantly what their goals are and what their progress is or lack of progress is towards the goals, ask why they're not changing, or say, can we talk about changing them? Because maybe they're just not the right goals anymore. Everybody's goals change over time. So you should always know what the goals are, be involved in the writing and rewriting process. You should always get reports about progress or, again, lack of progress towards the goals, because all of our goals change over time, right?
Yeah. And to be age appropriate. I find oftentimes in Rett syndrome that we don't move on with our tweens and teens to move on to things that are more, say like manicures or picking jewelry or advancing music. They get comfortable in more of the pediatric type activities, and our kids can get bored with that. So we have, if everyone would take some time to join our IRSF YouTube channel, we have so many videos out there that were done, particularly during the early days of COVID, that talked a lot about different activities that can be done at home, baking, cooking, using everyday objects to engage your kids. And I think that these are relevant to our life always with Rett syndrome. So go and look at some of those other videos. You'll find adapted switches for games, adapted switches for helping assist with cooking and baking in the kitchen. I know you all talked about that. If we can make those fun activities, everyone's life will be better, including, I can say that as a parent, that we can get bored too, trying to make every moment an enriched therapeutic moment, but we all benefit from these activities. So anyway, we could go on and on and on. I'd like to encourage everyone to join us again next month. Our next Rett Ed will be in the area of music therapy. And we talked a lot about music therapy and the use of music and its benefits in Rett syndrome. We'll be hearing from some experts next month. So again, thank you for your time. Please keep doing your work. Todd, Emily, we really need more experts in this field, and you touched on so many subjects that we could go to in depth, but hopefully everybody who attended today walked away with at least one idea of an area to try and get over somewhere that you have felt stuck or frustrated, or that you didn't have an answer for. And if we did that successfully, then we met our goal. So hope to see everyone in Nashville in April. Hope to see you online next month as we talk about music therapy. And until then, please enjoy the holidays. I hope you all have a chance to rest, renew, and get prepared for what we hope will be a very exciting 2022. Yeah. All right. Thank you very much. And that concludes today's webinar. Look for the recording on our YouTube channel, and we'll talk to you again soon. Take care, be well, get vaccinated, and have a happy holiday. Thanks. Bye-bye, everyone.